Good morning. My name is Francisco Flores, and I'm an associate professor of pediatric nephrology and hypertension for Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. I would like to thank Dr. Felipe Cabañaro and the organizing committee for the opportunity to be here with you today and talk about acute renal replacement therapy in the era of COVID-19. Some housekeeping issues. I am a consultant for Baxter, for Medtronic, Alexion, and GlaxoSmithKline. In the next 45 minutes, my goal is to review the incidence of COVID-19 associated AKI, review the risk factors in the pathogenesis of AKI associated to COVID-19 infection, to discuss the indications to initiate renal replacement therapy, to discuss the preparation to protect the staff, to deliver the therapy and to meet the demand, and to discuss acute renal replacement therapy in COVID-19 associated AKI. The incidence of AKI associated with COVID-19 infection was recently published by the SARS-CoV infection pediatric acute kidney injury registry in collaboration. And they reported this sequential point prevalence study of children and young adults aged between 17 and 25 years old admitted to the ICU under investigation for SARS-CoV-2 infection. 331 patients were included, 51 were confirmed cases of COVID-19, and the incidence of death was 4.2%. AKI occurred in 37.5% of the cases, and severe AKI was present in 19% of the patients. The incidence of AKI in the confirmed group was 41.3% versus 32.9% for the suspected group. Severe AKI occur in almost 90% in the confirmed group and 18% of the suspected group. The mortality was 6.2% in the confirmed group and 9.5% in those in the confirmed group who developed AKI. How the patients presented, by far the most common form of presentation was respiratory distress in 50.3% of the cases, shock and hemodynamic instability, and sepsis. Of those patients who were admitted to the intensive care unit, approximately 19.6%, approximately 20% of those patients presented with severe AKI, defined as a stage 2 or stage 3. In addition, those patients who had AKI either in the confirmed or suspected group, as seen in this bar table, they require more invasive respiratory support, they require more vasoactive utilization, they require ECMO support, they tend to stay in the hospital longer, and also the 28-day hospital mortality was significantly higher in those patients who had confirmed COVID infection and developed AKI. Other studies that look into the incidence of COVID-19 associated AKI was this paper by Basilelli that looked into 166 children admitted with acute COVID-19 or multi-system inflammatory syndrome associated with COVID-19 infection. Almost 12% of those patients developed AKI. 50% of the patients who developed AKI presented with gastrointestinal symptoms. Of those patients who presented with AKI on admission, they tend to have a higher white blood cell count, lower albumin levels, and higher C-reactive protein. Patients who develop AKI after being admitted, in most of the cases, was related to exposure to nephrotoxins. As you can see in this diagram, 6.2% of those patients who develop AKI had stage 1, 1% had stage 2, and 3% had only, and 1% developed stage 3 AKI. Of those patients who develop AKI in this group, they require more inotropic and vasopressor support, and the length of hospital stay was significantly higher. But in this consensus report by the Acute Dialysis Qualitative Initiative, they look into the potential risk of all the patients developing AKI after COVID-19 infection. As you are aware, patients who are older with diabetes, hypertensive, cardiovascular disease, with a high body mass index, chronic kidney disease, immunosuppression, and smoking history, they have a higher risk of developing AKI after the COVID-19 infection. Also, they look into the risk factors for AKI at admission. Patients with severe COVID-19 at presentation, degree of viremia, respiratory status, leukocytosis, hypovolemia, rhabdomyolysis, exposure to certain medications like ACE inhibitors and ARBs. And also look into the risk factors for AKI development during the hospitalization, such as exposure to nephrotoxic medication, the need of vasopressors, the need of ventilatory support, and also the fluid dynamics. In the pediatric study by the Spark investigators, they also look into who are the patients at risk of developing AKI after COVID-19 infection. And what they found was patients who are over the age of 13, they have higher incidence of or higher risk of developing AKI after the infection, and also patients who presented with CNS symptomatology at the presentation also had a higher risk of developing AKI. In terms of ethnicity, Hispanic patients after multi-regression analysis was found to have a higher risk of developing AKI related to COVID-19 exposure or infection. But patients who develop or get COVID-19 infection, the pathogenesis of the development of AKI varies according to the patients. Sometimes it's related to dehydration, either because of decreased fluid intake because of the severity of the disease, or because they have vomiting or diarrhea. Also because of the overuse of diuretics when we try to overzealously control or prevent fluid overload. Also the presence of cytokine storm with high interleukin-6 levels, the development of ARDS, the presence of capillary leaks, or patients who presented with shock. Can be related to interaction between different organs, for example, pulmonary, renal, cross-organ talk, due to hemodynamic instability and co-infection, especially pulmonary over superinfection by bacteria, also can be the reason for them developing AKI. Can be related to systemic side effects of the virus, like direct viral injury of the renal tubules, or exposure to nephrotoxic medications such as antivirals. Those patients with COVID-19 infection and at risk of developing AKI, we have to be very careful with the medical management. And in this paper by the Acute Disease Qualitative Initiative, look into the strategies to medically manage those patients, including providing a standard of care to decrease the risk of development of multi-organ failure, individualized fluid management to prevent fluid depletion or fluid overload, to consider hemodynamic monitoring, monitor the serum creatinine and urine output on a regular basis, correct hypoglycemia, consider alternative of radiocontract exposure, avoid potential nephrotoxic agents as much as possible. Consider changing the dose and frequency of the medication based on the current estimated glomerular filtration rate, and also consider renal replacement therapy after medical therapy has not been adequate to control the progression of the disease. In the pediatric population, the way we have to be careful about those patients, we have to assess the volume on a daily basis, and also consider non-invasive hemodynamic assessment by Doppler ultrasound or echocardiography. We need to individualize the fluid balance in order to prevent volume depletion or prevention of fluid overload that exceeds 10%. It's important to measure serum creatinine electrolytes on a regular basis every 24 to 48 hours. It's very important to monitor the urine output and also review the medication daily and withhold those that have potential nephrotoxic effect, and also adjust the dose according to the current glomerular filtration rate. If, despite of very aggressive and very careful medical management, the patient continues progressing and has developed an acute kidney injury, we have to think very carefully about what are the indications for them to be initiating renal replacement therapy. As you are aware, if there is significant acid-base disturbance that is not responding to the medical therapy, if there is significant electrolyte imbalance that is not responding to the medical therapy, especially hyperkalemia with EKG abnormalities, if the patient has symptomatic uremia with encephalopathy and bleeding, if the patient is significantly fluid overload, symptomatic such as hypertension, pulmonary edema, it's not responding to the diuretic therapy. And also, before we start, it's very important for us to consider the availability of the resources in the institution that you are practicing. In this consensus by the Acute Disease Qualitative Initiative work group, they look into the recommendations for renal replacement therapy in patients with COVID. One on the right side of the table, you will see what are the considerations for renal replacement therapy for COVID-19 associated AKI, and on the left side of the table, you will see how we manage renal replacement therapy when there is an increased demand for us to provide this particular type of therapy in patients with AKI. They look carefully into the renal replacement therapy indications on what are the modalities of choices, what is the renal replacement therapy dose, and also discuss vascular access in this particular population. Also, they review the renal replacement modality options in patients with COVID-19, and they look into advantages when you provide intermittent hemodialysis, prolonged intermittent renal replacement therapy or CRT, or patients who are receiving PD. Also, they look into the potential disadvantages when you provide this particular therapy in patients who have COVID-19 associated AKI. But before we initiate renal replacement therapy, I think it's very important for us to consider the following. We have to prepare for the increasing demands in many hospitals, especially here in the United States, in terms of pediatric hospital in New York. During the second wave, they had a significant increase in their demands compared to the supplies that they had available. Also, very important to protect yourself and your team. Be flexible, and we need to adapt. So in terms of be prepared, and this also was reported in the consensus report by the Acute Disease Qualitative Initiative. When you're facing a pandemic or disaster, you have to think about the increasing in renal replacement therapy, and also reduction in the ability of us providing renal replacement therapy. This can potentially put us in a crisis in terms of the ability to provide renal replacement therapy. And we have to look into what are our ultimate goals, which is, in the worst of scenarios, to provide a greater good for a greater number of patients. What are the local responses? And in moment of crisis, we need to triage allocation system to be able to meet the demand. And also, what is the regional or national response? And unfortunately, sometimes we have had to establish criteria for us to be able to allocate those resources available for the provision of renal replacement therapy. In this paper in Frontiers in Pediatrics, the Pediatric Continuous Renal Replacement Therapy group had a position mainly to try to establish what is the algorithm thought or the thought process when we're facing the pandemic and an increased risk of demand to provide renal replacement therapy. The acute renal replacement modalities in the ICU included continuous continuous renal replacement therapy, or SLED, which are the patients that were receiving continuous renal replacement therapy, or short-term renal replacement therapy, also known as PERT, which are the patients who are going to be receiving SLED, and which are the patients who are considered to be a PD candidate. Also, they look into the which are the anticoagulation protocols or strategies that are going to be available to be used according to the patient's need, and also the recommendations in terms of vascular access. So how do we protect ourselves and our team? One is by limiting exposure to the absolute minimum. Depending on the design of the renal replacement therapy team in your hospital, either we have to allow only the CRT bedside nurse to provide the therapy versus the dialysis nurse. The CRT machine setup is outside the room. We use sometimes in adults the extension tubing, and we'll go into more details in the next few slides. And use of telemedicine, both or cell phones, to troubleshoot any issues out from outside the room. So in our institution, we develop a guideline for the delivery of extracorporeal therapies for patients with suspected or confirmed COVID-19. We made the decision that patients who develop AKI associated to COVID-19 infection will be managed with, we will provide supportive therapy using CRT. The CRT machine will be set up and prime outside the room. The bedside IC nurse was or is responsible to connect the patient, start the therapy, and provide ongoing therapy. And this, of course, in our institution was oversaw by the CACA nurse. In our institution also, the standard of care is to replace the circuit or the filter every 72 hours. But in patients who are hemodynamically unstable, we'll extend the filter change up to 7 days. And again, any troubleshooting changes in the prescription was done via telemedicine, VoLT, or cell phones. So, but not every single institution had the opportunity to do that, either because of the volume or because before they knew the pandemic was knocking at their door. So we have to look into which is the preferred renal replacement therapy during COVID-19 infection. Well, the selection of the modality is based on the patient's needs, the local expertise, or the ability of the staff and the machines. The modalities depends again on the institution, intermittent hemodialysis, peritoneal dialysis, or continuous therapy such as CVVHD, CVVH, CVHDF, or PERT. So which is the best one? Well, we have to keep in mind that intermittent hemodialysis, provision of this therapy reduces the need of anticoagulation. It's of short duration. More patients can be receiving this therapy in a day. However, you need specialized nursing staff to be able to produce this therapy, and also you have an increase of more staffing getting exposed. Use of peritoneal dialysis, and the benefit is that you don't need a vascular access, you need less equipment, there's no need to for anticoagulation. However, this presented a significant challenge in general in those patients who are placed in the prone position, because they noticed there was a decrease in ability to provide the therapy adequately, and also an increased risk of peritoneal fluid leak. Continued therapy is the therapy of choice in patients who have hemodynamic instability, patients who poorly tolerate any changes in fluid status, and any patient who had significant fluid overload. In this paper by Dr. Claudio Ronco, they look into the way they thought and they plan to deliver continuous renal replacement therapy in patients with COVID-19, where they carefully look into the indications, the preparation, how they're going to prescribe the therapy in terms of not only the vascular access, the dose, anticoagulation, how they're planning to make sure that the dose and the therapy was delivered efficiently, and also how they monitor the efficiency of the therapy in terms of making sure that the vascular access was working properly, that the anticoagulation goals were met, etc. So I don't know if you remember one of the previous slides, I talked about being flexible and being adaptive. And this is very important when we prescribe the therapy, because we have to make some adjustments in terms of the CRT prescription in patients who develop AKI related to COVID-19 infection. So in terms of blood flow rates, as you know, the adequate blood flow rate is depending on how good of a vascular access you have. In general terms, the minimal blood flow rate in pediatric is 5 mLs per kilo per minute, and the average is between 5 and 12 mLs per kilo per minute. With the Prismaflex machines, you need to keep a minimal blood flow rate of 30 to 50 mLs per minute to prevent alarms. And you need to keep the access pressure to less than 250 millimeters of mercury and the return pressure more than 10 and less than 200 millimeters of mercury. So a few key important points about the vascular access. The placement of the vascular access, who does it, is based on the experience and preference. The IJ remains the first option and is recommended to use the ultrasound guidance for catheter insertion. However, prone position, obesity, and hypercoagulability can affect how good this catheter is going to be working for you. Extension tubing became a very important tool in adult centers providing continuous renal replacement therapy. As you can see, this machine was set up outside the room, and the tubes were coming in between the cracks of the two doors. So what is the benefit of using extension tubes? Well, it reduces staff exposure to suspected or confirmed patient of COVID-19. The things that you have to keep in mind is that every single tube adds 70 to 80 mLs per tube of extracorporeal volume. Therefore, for you to be able to prevent alarms due to access pressures, you need to increase the blood flow rate. And also, because of the significant extracorporeal volume, your patient will be at higher risk of developing temperature instability. Just to remind you about the CRT filters or hemofilters available, at least in the United States, for the provision of continuous renal replacement therapy. We have the M60, M100, M150, HF20, HF1000, and HF1400. The M filters are AN69 membranes, and the HF filters are done. The HF20 filter was approved in the United States in 2020 to provide continuous renal replacement therapy for patients of 8 to 20 kilograms. The hemofilter surface area is 0.2 meters squared. The priming volume is 60 mLs. The minimal blood flow rate that you need is 20 mLs per minute, and the max is 100 mLs per minute. So this is just a picture of the HF20 hemofilter circuit that you have that we have available. So the hemofilter was approved in the United States to be used in patients with small weight during the COVID-19 infection. Stuart Goldstein and the rest of the investigators did a clinical evaluation of the Prismaflex HF20 for acute continuous renal replacement therapy in children of low weight who develop acute kidney injury. As you can see in this table, there was a significant improvement in the BUN reduction, and the HF20 filter achieved the 24-hour BUN reduction required by the FDA, which was a minimum of 38%. None of the patients required blood prime for the CRT circuit. Other filters that were approved by the FDA to be used in patients with AKI associated with COVID-19 was the Cytosorb, which is a biocompatible absorbent bed-filled cartridge that removes substances up to 60 kilodaltons, the most common ones inflammatory mediators. This is a non-specific or molecular site absorptive mechanism, and the treatment duration was 72 hours. The Oxiris filter is a multi-layer high-absorption polymer membrane AN69 that removes endotoxin cytokines and inflammatory chemokines. Was approved by the FDA in April of 22 for the management of cytokine storm triggered by SARS-CoV-2 infection. And the Seraph filter is a sorbent hemoperfusion device that contains polyethylene beads coated with immobilized heparin. This binds directly bacteria, fungi, and viruses, including SARS-CoV-19 too. So a few words about Cytosorb. Was granted emergency use approval by the FDA in April of 2020. Treats hyperinflammation in adult COVID-19 ICU patients. The circuit can be incorporated into extracorporeal circuits, including ECMO to treat ARDS refractory to conventional mechanical ventilation and COVID-19 infections. This report by the Multicenter Retrospective Registry collected data between April of 2020 and April of 2021. 52 COVID-19 patients on ECMO were treated with Cytosorb. And in the last portion of the table, you will see patients who were treated with this filter require less duration of the of the ECMO therapy. They require less duration of the renal replacement therapy and require less plasmapheresis, although none of those differences reach significant difference. The Oxiris, as I mentioned before, was approved by the FDA. The primary volume is 193 mLs. The minimum weight for its use is 30 kilograms, has a surface area of 1.5, and the blood flow rate that is required is at least 100 to 450 mL per minute. In this observational prospective study of patients admitted to the ICU with COVID-19 and who developed AKI, 37 patients were treated with this particular filter, and as you can see, there was a significant reduction of interleukin 6, and this was particularly true in the first 24 hours of initiation of the therapy. Also, there was an improvement of the multi-organ function that was associated with the improvement of the interleukin 6, and this improvement of the hemodynamics was reflected and based on the improvement of the SOFA scores. In this report from China, they looked into patients in a single center that were treated with AKI associated COVID-19 with this AN69 membrane. And as you can see in red, patients who survived, they had a significant reduction in the interleukin 6 compared to patients who did not survive. The SERAPH microbiome affinity, this initial report looked into the first two patients who were treated with this prior to the FDA authorized the use of this filter for the management of AKI associated to COVID-19. As you can see, there is a significant reduction of the viral copies in filter 1, 2, and 3 after the patients were treated with this therapy. Also, patients who were treated with this SERAPH 100 microbiome filter, they have improvement of the hemodynamics, which was based on the reduction in the requirement of norepinephrine and vasopressin. And also, as you can see at the bottom of the table, patients after they received therapy with this particular type of filter, there was removal of the or improvement of the viremia. Let me share some of our experience, and these slides were provided courtesy of Dr. Kyle Merrill and Stuart Goldstein. We had a patient that was treated with this SERAPH 100 microbiome affinity blood filter. This patient is 17-year-old African-American male diabetic with asthma who was admitted with COVID-19 associated pneumonia, rhabdomyolysis, and acute kidney injury requiring renal replacement therapy. At day 4 of admission to the intensive care unit, the filter was approved to be used in this particular patient. As you can see, there is every day after the filter was used, there is improvement of the oxygenation markers. Also, there is improvement in the inflammatory markers. There's improvement in the cardiovascular stability based on the less requirement to norepinephrine dose. Even more, we were able to quantify the N protein, which is the presence of the virus in the blood, and there was a significant reduction. At the same time, there was a significant improvement in the spike IgG levels. So in general terms, there was improvement not only in the hemodynamic oxygenation / ventilation status of the patient, but also there was a reduction in the presence of the virus in his blood. Anticoagulation during COVID-19 infection is very challenging because many of those patients, they are in a hypercoagulable state. Therefore, they are at risk of thrombotic complications such as pulmonary edema, pulmonary emboli, and deep vein thrombosis. Also, the high inflammatory response due to cytokine storm contributes to the frequent filter clotting. Therefore, this is associated with a more consumption of the resources, increasing downtime, inadequate dosing, increasing staff exposure. So there have been multiple reviews in single center reports of the different anticoagulation strategies to prevent filter clotting in those patients treated with continuous renal replacement therapy. As you can see in this table, there have been many attempts to provide adequate anticoagulation. However, in the best of the scenarios, as you can see in the findings, you can see circuit life between 4.1 to 12.3 hours, regardless if the patient is receiving systemic anticoagulation or regional anticoagulation with a citrate. But not everybody had exactly the same experience. In this publication by Dr. Michael Hong in Michigan, they look into 32 patients who were admitted to the intensive care unit in Michigan and require renal replacement therapy. They received citrate anticoagulation, but they didn't have the same experience in terms of filter life. The median circuit survival was 53.5 hours, and they were able to provide adequate therapy without significant interruptions. So just to summarize some of the different strategies that are available specifically during COVID-19 infection, was systemic heparinization with a bolus of 20 units per kilo, followed by infusion of 20 to 30 units per kilo per hour. The target of the ACT was 180 to 220 seconds, PTT between 60 to 90, and if you follow anti-10A, 0.25 to 0.3. If despite of adequate anticoagulation, you continue seeing frequent filter clotting, some institutions ask prostacyclin at a dose of 4 nanograms per kilo per minute. Other institutions prefer citrate or regional anticoagulation. And what they target is an ionized calcium in the circuit with less than 0.3, usually between 0.25 to 0.35, aiming also for an ionized calcium in the patient between 1.1 to 1.3. If despite adequate anticoagulation with citrate, you continue seeing frequent clotting, the recommendation is to add heparin to maintain the filter life. In terms of dose, and again, we're going back to the terms of being flexible and also being adaptive. In general terms, the dose that is recommended for an adult is a delivered dose of 20 to 25 mL per kilo per hour. However, when the patient has achieved adequate metabolic and fluid balance, if there is significant issue with the supply availability, the recommendation is to reduce the target dose that you have in mind. In pediatric patients, the standard dose, as you know, is 20 to 60 mL per kilo per hour, or the way that we dose is 2 to 3 liters per 1.73 per hour. However, the pediatric continuous renal replacement therapy group had the recommendation to provide a dose of 50 mL per kilo per hour for 12 hours, followed by a reduction in the dose to 25 to 30 mL per kilo per hour. However, when you are facing a significant shortage because of the high demands and your machines now are limited, the recommendation in pediatrics, and this is based on Dr. Akash's paper, is to provide 50 to 60 mL per kilo per hour, or 4 to 5 liters per 1.73 meters squared per hour for 8 to 12 hours, followed by 20 to 30 mLs per kilo per hour if you notice that the consumables are becoming more and more limited. Now, which is the preferred CRT modality during COVID-19? Well, many of you probably remember that in the past, the theory was that convective therapy were more efficient to remove cytokines, and this was particularly true when we were using with the first studies using AN69 membrane. The current recommendation for the patients with AKI associated COVID-19 who are requiring renal replacement therapy is to provide continuous veno-veno hemodialysis or CVVHDF, and this is based on the recommendation of the Acute Disease Quality Initiative Consensus Report. The Pediatric Continuous Renal Replacement Therapy group recommend the use of CVVH following the rule of one-third. That means that the dose was divided in one-third as a pre-filter delivery, one-third as a dialysate, and one-third as a post-filter infusion rate. However, I think that it's very important that to keep in mind that the modality of choice is center dependent, and we need to try as much as possible to continue using the same approach to prevent confusion and mistakes. This is in particularly true because we have seen a significant turnover with the nursing staff. So educating every single group of new nurses with different therapies, different modalities will be putting the patient at high risk of mistakes and medical errors. So just to summarize, we need to be prepared, or we were also, we try to prepare. It is important for us to try to protect our staff and ourselves by minimizing any potential exposure. We need to be flexible and adapt according to what is available and what the needs are. We need to develop a plan not only for the hospital, but also for the program to be able to deal with the demand. We have to maximize medical management, especially the fluid management prior considering renal replacement therapy. In adult institutions, they try at least to manage aggressively fluid overload for 72 hours before the patient is actually connected to a renal replacement therapy machine. We have to adjust the continuous renal replacement therapy prescription to match the needs with the demand. And we have to be prepared to adapt accordingly to the staff and supply availability. Well, thank you very much for your attention, and we'll see you guys for later on for any question. Thank you very much. Have a good day.